May I offer a warm welcome to this debate and express my thanks to Alzheimer's Scotland and to TC Young for organising it, and in the case of TC Young for paying for it, in response to the issues raised in my book, Where Memories Go, Why Dementia Changes Everything. Just a couple of housekeeping notes before we go any further. There's no fire drill scheduled, so if we hear the fire alarm sound, could we make our way to the closest emergency exit and assemble outside number 12 Hill Square. Could I ask you also to turn your mobile phones off, but well, maybe don't turn them off, turn them to silent, because you're very free to tweet if you wish, and the hashtag is AltScotWMG. Now, I'm not going to take up a lot of valuable time talking about my book itself. Some of you will have read it, and I know Waterstones will be delighted to part with a few more copies to anyone who's interested downstairs. And if anybody didn't get a copy signed and would like to, I'll be very happy to do more of that later. Basically, though, it's one family story of accompanying a beloved mother through her 12-year-long experience of having dementia, which was eventually shown in her case to be a mixture of Alzheimer's and vascular dementia. It's about the ups and downs, the laughs and joys, as well as the frustration and tears that we experienced along the way. It's also, crucially, about the many practical, medical, social, and, of course, emotional challenges we faced in trying to look after our mother as well as we wanted to. Although my particular story is unique to my family, and I make no attempt to hide the fact that we enjoyed some advantages that others don't, including, for instance, there being 3 committed daughters to pitch in, and that was a matter of luck. Nevertheless, there are still many senses in which our experience could genuinely be anybody's. Not least in the fact that for much of the time we felt alone, lost, abandoned, confused, frustrated, frightened sometimes, and especially during a spell in hospital, quite boilingly angry. We had so much love to give, so much care to offer, but nothing available on the outside seemed designed to build on that, or to reinforce it, or to help it to outlast the increasingly demanding challenges of the condition itself as it progressed. As the people who knew my mother best, we seemed to be thwarted at every turn rather than welcomed as partners in her care. Now, there were, I should add, exceptions to that. A well-informed GP, some instinctively empathetic hospital nurses, a most magnificent palliative care team. And I should also add, it's become clear to me since then how much work is going on at many levels to try and improve the system, and I'm sure we'll hear all about that. One thing I would say about my book is that the response to it, since it was published not all that long ago, 3 weeks I think it is now, quite honestly has floored me. From the length and breadth of the UK, I've been deluged with letters, emails, Facebook messages, tweets from people telling me their stories. It's felt as if, for many people, a floodgate has opened of often long suppressed pain, grief, and yes, joy at what can be rescued and affirmed and enjoyed when truly person-centered care is in place. People have queued up at book festivals, literally, just to say, I'm there too. Pitlochry on Saturday was a case in point when I'd finished speaking, ending on the truthful, upbeat thought that whatever I had given my mother, she had actually given me more. A woman put up her hand and said in effect, it's all very well for you to say that, but my mother gives me nothing. All her aggression is directed against me, and I can't bear it. And she burst into tears, and I think 300 people in that audience felt like doing it with her. It is so painful for families, this condition. There's also, in many cases, a great deal of suffering for those who have the condition, and I don't believe we should shy away from acknowledging this. Although some are luckier than others, and there can be many years of happy and fulfilled life along the way if we as a community can learn to care for them properly as individuals. So that is the context of our discussion this evening. That is, I think we can all agree, the given. Our job tonight, with the help of a panel of top professionals in the field, is to discuss how society, as expressed in the structures that we've erected to deliver care, and in theory at least to protect the human rights of all our citizens, can do better. Where does the action need to come? How should it be made to happen? We've gathered on the platform here an array of people deeply engaged across the whole field, and there are many more among you in the audience. I'll be inviting them to help us tonight to articulate a clear-eyed vision of what most urgently needs to be done and how that is going to be achieved. There's a huge area to cover. We're not realistically going to get to the heart of everything, but in the interest of trying to tether the debate and cover as much ground as possible, I'm going to stick quite strictly to 15-minute segments. The 5 areas we'll look at are care at home, acute care in hospital, residential care, diagnosis and stigma, and research. I think it's worth you knowing that, so that as far as possible we can keep any questions or comments confined to those areas. I should tell you that Alzheimer's Scotland has been inviting questions via Twitter and Facebook, and I've got these to hand, and I'll try to insert the gist at least of some of them into the discussions as we go along. I hope people will forgive me if I don't manage to cover everybody's questions, but we'll see how we go. And similarly, I'll be delighted to get points from you in the audience to our panelists. Just raise your hand and we'll get a mic to you. But it would be great if you could respond to the ebb and flow of the debate and keep us to the point within these sections as much as possible. So it's now my great privilege to introduce our cast of thousands here who've been waiting patiently. Jeff Huggins here is Head of Mental Health at the Scottish Government. He's been involved in creating the National Dementia Strategies 1 and 2, making sure that they are implemented and assessing their impact. Next to him, we have Leslie Hurst, partner in solicitors TC Young. She's one of only 7 solicitors in Scotland who's an accredited specialist in incapacity and mental disability law. Legal decisions, of course, especially around power of attorney and guardianship, are often one of the more difficult aspects of planning and managing a life affected by dementia. Ranald Mayer, Chief Executive of Scottish Care. Scottish Care represents residential care and care at home services, 2 hugely important areas for people with dementia and their families. Anna Fowley is Chief Executive of the Scottish Social Services Council, who work in conjunction with NES, Malcolm Wright we'll hear about in a minute, to improve standards of dementia knowledge and training. Then we come to Dr. Peter Connolly, who's co-chair of the Scottish Dementia Research Consortium, which aims to support the development and expansion of high-quality, coordinated, collaborative dementia research throughout Scotland. Henry Simmons, next to him, is Chief Executive of Alzheimer's Scotland, a man with a finger in all the pies we'll be discussing tonight, but indeed a passionate interest in all of them. Ron Cully, Chief Officer of the Convention of Scottish Local Authorities. His role in COSLA ties him in closely with local authority planning and implementation of health and social care integration, something which will impact on the delivery of dementia services in Scotland, hopefully for the better. And we Malcolm Wright, there you are, Chief Executive of NHS Education for Scotland, or NES, which plays a key role in trying to improve dementia awareness and understanding within the healthcare workforce. As David Dimbleby would say, ladies and gentlemen, your panel. Jeff Huggins, if I could start with you. Sorry. We have had a lot of questions in via Facebook, and I know this just from all the people who have been getting in touch with me as well. If we look at care at home first, what people at home most desperately want, I think, is coordinated services. It's also desperately confusing. Who is in charge of joining things up?
Goodness, that's really quite a good question. And I suppose you can look at this from two ends of the telescope in terms of we have structures where we've got a national government, we've got local government, we've got care providers, we've got the NHS, with each of those looking to manage their own organisational needs and provide care effectively. We've got a strong commitment to personalisation within that. And the sense of that is that the people who should be in charge and who should be directing and assisting, I guess, with managing the coordination are families and carers. And I guess a lot of the time what we're faced with is the balance of trying to organise from the needs of the family and the individual, and at the same time balance that with the ability to get a workforce of 100,000 people out there tomorrow, going into people's houses, providing care, providing a range of services.
So are you saying that there's nobody actually coordinating services?
Well, there are a range. There are more than one group of people coordinating services, and that's part of the challenge. In that you can have a problem with coordination where you have too many people coordinating in the same way that if you don't have enough people coordinating. And I guess this is one of the objectives that we have under health and social care integration, which is to try and get beyond this idea that we've got the health board who do what they do, and we've got the council and they do what they do, in that we need to be able to find a better way both to commission and to organise services at macro level, but then to take that down to the local level. And a lot of the work that we've done through the dementia demonstrator work, post-diagnostic support, and the work that we're now doing on the 8 pillars is trying to find ways of actually solving those problems at atomistic level, right down in towns and villages and street level. Because if I sit in my room in St Andrew's House, and I've got quite a nice room and I've got a good view, and I think of what the solution is to what services should look like in Rothsay, I'm probably not going to get it right. So what we need to do is to create structures and approaches under which we're actually building these solutions at local level between maybe 2 care providers, maybe one council, maybe a health board, but also organisations locally like Alzheimer's Scotland and their support work. So you could imagine, or you could believe, some totalitarian state where we would solve that problem for you. But the answer is it's probably a lot likely to be better solved at the local level within a framework which we create, and that's what we're after.
So Ron Cully, is it going to be solved at the local level then? That's the theory.
Yes, I think there's a lot of hope to say that it can be, and I mean, to echo Jeff in a couple of respects, at a strategic level what we anticipate is the legislation which will come to its final conclusion tomorrow, that's going through the Parliament in respect of health and social care integration, will identify a single individual, a single point of accountability in each and every local authority area who will have responsibility for strategic commissioning in an area. And what I mean by that is that that individual and the people that work with him or her will be responsible for putting in place a range of service options that are capable of meeting individual need. But that of itself won't be enough. And it doesn't directly get to the heart of the question that you asked, Sally, because I think what we need to think about there are patterns of service delivery and support arrangements that we can see on the ground. And I think that's where the notion of commissioning has to connect with something more real. To bring it back to something that Henry came to speak to us about a year or so ago, this idea of the 8 pillars model. At the heart of that, there is a sense of coordination. That's one of the virtues of that model, that working with individuals and their carers we will be able to effectively coordinate service and support mechanisms around the individual. Now, we're still developing those ideas. We're still trying to see how best that can be implemented. So we're by no means there yet. But I think...
Is this an aspiration, Ron, or is this something that you are able to say that as a result of the health and social care integration is going to happen?
Health and social care integration will be the law, so that will happen. The models of delivery that I referred to in respect of the 8 pillars is happening, but it's happening at a pilot phase just now. We anticipate that that will be looked at and rolled out. So yes.
And then I'd like to have a question from you.
Just to bring another couple of points into the mix in this, and that's, there needs to be an empowerment agenda. That is, it's not just about people from local authorities and health boards getting their act together. It's empowering carers, families, service users to have a say and to have control. And at the level of community, the legislation does put an emphasis on locality planning, because even within a local authority or health board area, the solutions are not necessarily going to be the same. I was talking about this in Fife. The solutions for St Andrews aren't going to be the same as the solutions for Kirkcaldy. So the empowerment of both the families, the people receiving services, and the empowerment of localities to have a say in the style and in fact, maybe even a control over some of the resources.
Who's going to make sure it happens, though? This is what I don't understand. I mean, it sounds wonderfully aspirational to me, but...
I think it goes beyond that, Sally. I mean, that is, alongside the health and social care integration legislation, from April, the Scottish Government rolls out self-directed support, which says in law, I am entitled to have control of my care package. So we need to encourage a degree of assertiveness, and the advocacy groups that support people have to be strong in saying, encourage people to be a bit more challenging, a bit more demanding.
So it's up to us, you're saying? Yeah?
No, I'm saying that the legislation makes that possible, and what we have to do is to support people to do it. Simply relying on the people in suits to determine what you need, even if we come up with the solutions, that you get more of the same. Exactly. So in a sense, if we want different solutions, we've got to take people with us on this journey.
Let's hear some points from the floor. Yes, we'll just wait for a mic, and then if you wouldn't mind just giving your name and organisation if it's appropriate.
My name's Colette Gregg. I'm retired from the NHS, but I was lead nurse for community, so I have a lot of awareness about dementia within people's homes. And there's been a lot of publicity recently about a named person for children. I mean, what do people consider about a named person who coordinates the actual on-the-ground care and has some authority to pull that together? Because people in Fife, there are different services there from Edinburgh, but a local person, for example, a district nurse, a health visitor, or a social worker would know what the local services were.
Okay, that's a good point. Well, I'll go to them in a moment for that. Another point? Yes, up the back. Pass the parcel.
Hi, my name's Katrina Mcmillan, and I'm a carer for my mother, and she lives in Fife and I live in Edinburgh, and I work full-time, so that has its challenges as well. But what I'd like to say is that, you know, I think that the self-directed support has made a fantastic difference to our family. The reason self-directed support came about was because of the location my mum lives in Fife. There weren't any local services, any council workers who were able to come out. And I'm now on my 3rd care agency, but we now have a very, very good relationship, very happy mix. I have a private carer that we buy services from out my mother's pension, and we also get support once a week from Beeld Social Care and from Alzheimer's Scotland with a social visit, and obviously there's lots of family support. But for people who think, oh my goodness, that's going to be a step too far. All I can say is that, you know, it's been a huge relief to me.
Okay,
and yes,
thank you very much.
it's
Good
difficult
point,
to organise
Katrina.
the monies and things, but it really does make a difference.
Lovely, thank you. Anna, Colette's point, a named person for dementia.
Yeah, it's interesting because I think the debate about the named person under getting it right for every child has been one of the most misrepresented bits of policy ever in the press. It's its heart. It's a really good idea for exactly the motivation that you've said there, and I would support that. I mean, there has been talk in the past about GERFEF instead of GERFEC, which is getting it right for every family, and I don't think we're anywhere near that place. It would obviously be controversial because we've seen this notion of a state guardian watching over everyone, Jeff Stalin estate kind of thing. It is not what it's about, absolutely not what it's about. And what it's about is helping you manoeuvre.
You probably get less resistance among families.
But it's not been families that have resisted this, it's been organisations who've misunderstood it.
But if you take it away from the children, which is a different point, I mean, how practical would it be to have a named person? Actually, I won't ask you, Anna, because Jeff wants to speak, but also just a word from you, Henry.
Yeah, I suppose your idea is exactly the idea that we've been hearing about for many years, and what we've tried to do is to try and understand how that might work within our current health and social care system. So we took a long time to develop this 8-pillar model that you've heard about, but what the important thing about that model is, it's not just about having a named person or even having a coordinator. It's about having a professional that's empowered to draw on all the other professional skills and expertise to make it work for that individual and the family. And I think that what we're quite interested in at Alzheimer's Scotland is how we can utilise the social care supports that are put in a more therapeutic way by perhaps connecting that better to your psychiatrists, your GPs, your allied health professionals. And at the present time, I don't think the system allows that to work too well. So if we can demonstrate through that work that new introduction of a dementia practice coordinator is the title, if they can make all the other aspects of the care system work well to improve the person's life and help them live well, that should have big impacts in terms of the family pressures, maybe the residential care system, maybe acute admission to hospital, and all the things we know doesn't work too well. Just by getting that bit right, it may work. But before that, we've also got post-diagnostic work in Scotland, where everyone gets a link worker for a minimum of 1 year. And what we hope that will do is allow people to live quite well for a couple of years if they get a timely diagnosis. Now these two big steps are crucial, and I think that's quite good progress. And if we can prove the viability and the effectiveness and the therapeutic effectiveness of what we're describing, I think that'll be really helpful to keep the argument going in the longer term.
Jeff, is it practical?
Yeah, it is, and we're currently, as Henry's mentioned, working through the use of the idea of a named person already as part of the post-diagnostic support. We're testing the idea at the next stage in terms of the care coordination. I think the challenge is having the idea of a named person isn't enough. It's actually how everybody else around the system works with that person and the degree to which they have real clout or they don't have real clout. And that requires a bit more than just having the idea. And that's why, and it's, as Henry says, it's not a new idea. This is an idea which has been around since the 80s. It's been trialled and it's been piloted and it's come and it's gone. And actually getting it to work differently this time around is the challenge.
And what stopped it working before then?
I think it's we end up, and certainly my experience in other areas of working in mental health is we come across organisational policies. So our corporate service requires us to have our own risk assessment for this care service, as well as the council risk assessment for this care service. And they're maybe being seen by 2 different clinical teams, so each of them have also got a separate set of files. And each of them, for the particular thing which they do, are the most important person. And in some ways, there's a wee bit of this challenge, which is to give everybody to give up something to allow the system to work a bit better. But that's hard when everybody wants to give the best clinical practice or the best social care practice. So giving up a wee bit is, to get a better overall picture, is challenging. A lot of it's about human dynamics. It's about how organisations work and about how people work. So the real challenge is to go out and test how we can work better with how people work in systems, rather than simply saying, we'll have a named person.
So Anna, what's it going to...
Well, to be fair on the post-diagnostic support work, we took that through a 2-year pilot process, and we're now rolling out as a national commitment that everybody with a new diagnosis will get 1 year of post-diagnostic support. So that's fairly rapid. And we've done the same, we're doing the same with the 8-pillars work, which is we're saying we're going to run this as a pilot across 4 or 5 areas over the next 18 months to 24 months, after which we will then implement. And part of that's the story of not promising to do 100 things, saying there's 5 things which we're going to do really well in the next 2 or 3 years, and we're going to take them to delivery. You're exactly right. We promise too much, we try and do too many things, and that means we don't achieve what we need to achieve.
Okay, Peter.
I'm inclined to agree with my nursing colleague here about, ending up doing the same sorts of things. I mean, post-diagnostic support wasn't invented 2 years ago in a pilot. I've been in practice for 30 years this year, and we were doing post-diagnostic support when I started. I think that there's always been pockets of very good practice, and there's always been pockets where people have had nothing. And I think what folk have attempted to do now is to try and give people at least something, which was one of Sally's point in her opening address. I think that one of the biggest things that hold this up is not organisational policies per se, though, it's reorganisation. And it seems to me that in my professional life, every 3 years or so, just when you think you're making progress, someone wants to reorganise everything. And you then are told, well, you'll have to wait. You'll have to wait till the new organisation beds down. You have to wait for the new structures, the new committees. And all the things that you had ready to go all suddenly go into a little drawer where they then stay until some new person comes saying, wouldn't it be a good idea if? And I think that the challenge really for the group at this part, this behind the barrier here that we have, is, a protective barrier. I think the challenge is to set up a system that firstly isn't as obtuse as the one that we have at the moment, where you don't actually need a named person to navigate through it. It should be pretty obvious how you get things, and it's not. But I think what we really need is a way of ensuring that when progress is rolling on in its own inexorable way, that reorganisation doesn't stop that dead.
So how are we going
to... And that, I think, is the worry about this integration. The integration seems to be the outcome and not whether the services improve being the outcome.
So how are we going to sort that then, Malcolm? We'll need to move on to our next section, but okay, let's try and end this section with actually something we're actually going to do.
Yeah, I'll do that.
Yeah.
I mean, I think...
that will fix what Peter's just said.
I think one of the things that your book demonstrates very powerfully is the range of different workers that can come into a home, be it from the voluntary sector, be it from the statutory sector, to deliver bits of care. And I think as we move forward with health and social care integration, if we can get out of that a system that has better coordinated care and people who are educated and trained and who can work in the house in a much more coherent way, I think that would be good. I think one of the ways through this is not just through structural reorganisation. I think it's about how we integrate the workforce between health and social care, between the third sector and the independent sector. And given that there are many hundreds of employers in the independent sector, there are 14 health boards and 32 local authorities. There are many people involved in employing people who will come in and out of homes. I think we need to get beyond that into the skills that the frontline workers actually need and how we integrate that workforce and how we educate and train.
How do you turn that round?
Well, I think it can be done, and I think it is being done. I mean, for example...
How was the shout from that?
I think it is being done now. And, the positive side, the positive side of all of this, I think in terms of the strategy and the implementation of that strategy, I don't think in all my years in the National Health Service I have witnessed such a systematic approach to workforce development within the NHS and within social care. And, what's been done to support carers, what's been done to support health care.
So Malcolm,
it's not enough, but we need to do more.
The fact that people are obviously expressing scepticism suggests that it's not reaching the ground yet.
Sure. And I think people are right to express that scepticism, but I think we're down the road, and I think there's a real willingness to make this happen. And I think we need to integrate the workforce, and I think we need to educate and train the people who are coming into folks' homes to deliver this care. And if you think that some of the support workers who are going to deliver care are maybe on the minimum wage or close to the minimum wage, what are the levels of qualifications that they've got? How much do they actually know about older people's care and dementia? So I think there's something about, you know, teaching people about the aging process, and I think there's teaching people about relational skills and how to care for people and how to look after people more.